I'm joined today by some of my colleagues, Dr. Mark Drakos, Dr. Dan Markowitz, and Dr. Anil Ranawat are here to join me. Dr. Ranawat's an orthopedic surgeon, also specializing in sports medicine. He's a medical director at HSS Paramus, and he's also a team physician for the Rangers and the Mets. Dr. Markowitz recently joined here with us after training here many years ago. We recruited him back. He's an orthopedic surgeon at the HSS Stanford location, specializing in joint reconstruction, hips and knees. Dr. Drakos, who's visiting us tonight from the comfort of his own home, is an orthopedic surgeon in sports medicine and foot and ankle conditions at HSS. He's a medical director of HSS Long Island, and also helps take care of the New York Knicks and the UFC, among other teams. So collectively, I think that we all have quite a bit of experience recently with telehealth for sure. And I thought that we would have the conversation tonight among us, and we can answer some questions as they come in through the Q&A chat room from you all at home. Before we kind of kick off the Q&A session, thought I'd share a little bit about my own experience with telehealth. I was absolutely a skeptic when it came to bringing telehealth to orthopedics prior to the COVID pandemic. And one of my good friends who's an ER physician told me that they were using telehealth with great frequency at the Cornell ER. And I remember the conversation that I had with her back in February where I said, oh, I don't think that can work. We can't, what we do in orthopedics is hands-on and you have to examine people. And I was certainly a skeptic, and I was certainly forced into the telemedicine thing during the pandemic, and have been extremely impressed with what you can actually do. And so it has been an enlightening 6 months or so. And I think that probably if we get everything bad from COVID, the one good thing that may come from it is this medium of communication between patients and physicians. So I guess I would just start from a 30,000 foot view. Dan, what has your experience been with telehealth prior to COVID and during COVID?
So my specialty is hip and knee replacement. So a lot of the visit is really talking to the person. Certainly there's an exam portion, but as we all know from our training, the diagnosis majority of the time comes from the history. So it really forces you to really, be right there with the patient. You're face to face with them. You have 15 minutes, 20 minutes, however long the appointment was set up for, but you're really able to get a full history and story and not really have to really worry about the exam. So you can understand how their condition affects their life. So I think it's really given the patients a lot more freedom to just talk more. I think sometimes in an office visit where we're trying to get through the story to then get to the exam, to then get to the x-ray, to then sort of figure out what we're doing. But in these telehealth visits, there's just a lot more ability for us to listen, but also for the patient to listen to in the comfort of their home. Sometimes there's that white coat phenomenon, and people have questions, they forget them when they come to the visit. So I just think for everyone, it's a lot more calming, and you just have more time face to face.
Mark, did you use telehealth at all prior to the pandemic?
No, occasionally we'd have international patients where we did like kind of an electronic consult, but I had no real experience with telehealth prior to the pandemic. And I would echo your comments. I think, necessity is the mother of invention. So when we had the pandemic, when we weren't able to see our patients on a regular basis, all of us kind of had to adapt and got thrown into it. And I think, the information you can glean from a telehealth visit is still evolving. But I would also echo what Dr. Markowitz said. I mean, certainly, a lot of what we do is information transfer and educating patients and, talking about potential options. And you can do that from the convenience of your own home. So I think there's a lot of advantages for telehealth. I think that, again, there are certain things where you probably still need to see someone in person for, but a lot of the information transfer and the fact that we can now upload digital films to the telehealth so you can actually go over films with patients on their computer with them has a whole bunch of advantages.
Dr. Ranawat, what do you think the biggest asset that telehealth will play going forward, and where do you see the biggest deficits?
Well, just one thing before I answer that question is that I also did not do any telehealth before COVID. And now, it's kind of the thing, how can I not do telehealth for, the rest of my practice? It's become so mainstream for my practice. And the reason why it's become mainstream now is that I operate on a lot of young athletes who are all spread all over the country right now, especially with, colleges and high schools and things like that. And commuting to New York City or commuting to Stamford, Connecticut can sometimes be a bear. So I have kids, today I saw a kid in Minnesota, in Boston, and in Indiana via telehealth. All young college kids, all back at school, all who I probably would maybe try to communicate via email, which is not HIPAA compliant, and not really see them. They wouldn't see me. You can get a lot out of a patient and seeing, when they say they're doing bad, they're not doing so bad, and they're doing great, they're doing really well. You can really see a lot on their patient's face, as Dan said, and they can really help maintain that doctor-patient relationship, which normally kind of dissolves via email. And so in that respect, I think it's critical. The one, downside, if post-operatively a patient is having some problems, you need to see them sometimes, and you need to check their motion, check their, go through things and look at a wound and touch them. So, there are certainly limitations, but the best thing is that if you do a telehealth visit, you can assess whether, do I need to escalate this? Do I need to get into my office? It's kind of like your ER analogy. And a lot of times you can say, you're fine. You don't got to fly from Minnesota or find a new doctor in Minnesota, do all these things. I can just say, let's just revisit you in a week or so via another telehealth visit. So that's really what I think the power of telehealth is.
Yeah, I would totally agree with that part. I think that it has become a really powerful tool for identifying potential problems, for things that need to be seen, and reassurance for things that are actually doing okay, but are maybe normal in our world, but is abnormal to a patient experiencing something for the first time. And I completely agree with that. Dan, so Dr. Markowitz, sorry, I'm going the informal route, and perhaps it's because you got two buttons unbuttoned there today. So
Relax.
What do you think about seeing new patients by telehealth, and do you feel like it's appropriate or inappropriate to book somebody for surgery without ever seeing them in person? Because that's been a first for me.
I think it was a leap of faith that we all kind of had to take. And, like you said, necessity is the mother of invention. It just, we had no choice. People need help, and we were in a certain position where we weren't able to see them. And so we just had to do what we had to do. And I think we all can probably say that in the people that we had those experiences with, they had a perfectly fine experience. I don't think that I didn't have any complaints when I did surgery on someone where I met them for the first time in the pre-op holding area. Again, because it's not just a phone call, you really are seeing the person. You can see the pain in their face, and they can see the empathy in your face too when you're trying to help them. So I really didn't have a problem seeing new patients. I think that it was alluded to earlier, that it could be a good gateway where we can, is this something that can be done over at telehealth? Or, do we have to, as Dr. Ranawat said, escalate it and bring them in for a physical exam or more specific x-rays or imaging? On the surgery side, it is a little bit more challenging, but a lot of patients who end up coming to see us have already gone through some treatments, and they're really ready for surgery. And so a lot of times people, I think, are looking for the right surgeon and the personality of the doctor that's going to treat them. And I think that can definitely come across in a telehealth visit.
Dan, along those lines, now, albeit the nature of your practice being predominantly dealing with arthritis, so like a long-standing type condition, so I'd throw this one out to the group, would be, what about treating people non-operatively? Do you think that we are in a position, an adequate position virtually to make an assessment that somebody doesn't need an operation and potentially miss the boat?
Is that for me, or who's that for?
It's for anybody that'll talk back to me. Dr. Dracos.
There's always that concern. I think it's very pathology dependent, meaning there are certain things, like in my world, if you break your ankle or you tear your Achilles or something of that nature, a lot of times I'll just need to see the imaging to have a pretty good idea of what I'm going to recommend for you. The question is what are you going to potentially miss on a virtual physical exam that you would glean from an in-person physical exam? And I think those things are still evolving. But again, we're kind of pushing the limits as to what we can diagnose online. A lot of people are doing research on this. We're actually doing our own studies on this right now in terms of how accurate our diagnostic techniques are over online, and how much stuff we might be missing. But again, a lot of it, I think, is, information gathering and then education, and that part can be done, I think, very, very easily. And to Dr. Markowitz's point, a lot of people just want to have the conversation about what their options are, and that's the meat and potatoes of the visit.
Yeah, I think for the majority of orthopedic complaints across the board are things that are ultimately, or at least initially, treated non-surgically, aside from the acute type injuries, tendon ruptures, fractures, things like that. And I think for the people watching, I think it's good to know that from a surgeon standpoint, what we're gaining from a telehealth visit is an ability to identify things that need to be escalated. And certainly for myself, whenever there's a question and I don't feel confident that I have a very good sense of the direction that this is going, then, in those situations, I would defer to an in-person exam when necessary. What do you think?
The other thing I would say, Sam, is that's really powerful telehealth is, for me and yourself and maybe Mark more, is using telehealth to get advanced imaging. Getting an MRI or even a CAT scan based off, x-rays can easily be transported over telehealth, but most insurance companies now are requiring some degree of a visit, and a telephone consult isn't always considered appropriate. So I can tell in 30 seconds watching somebody limp across the room whether they really need an MRI of their knee or they don't. And likewise, I'm sure Mark can tell in terms of, a foot ankle, or even whether he needs a CAT scan for a type of ankle fracture, and you need a telehealth visit to get that. So the use of advanced imaging, and especially if you have somebody with an acute injury, the last thing they want to do is come see you, spend all day, get the MRI pre-cert, have to have another visit. So it's really decreasing hospital walkthrough and flow, and in this environment where you want to minimize the amount of actual physical touches, it's safety for the patient, and it's efficiency for the patient, and it's safety for the caregiver and efficiency for the caregiver. So that to me is really a win-win for telehealth about escalating in terms of more advanced imaging.
In all fairness, it does take Mark 45 seconds, not 30 seconds like you, to be able to make a diagnosis, but he's still working on getting that time down.
Not everybody can be a Neil or a Ranawat.
One thing
I would,
that
I would also add that I agree with Anil completely. The biggest advantage is convenience, especially for the patient. So historically, especially if you're coming into the city, a lot of patients take a half day off work, spending a half hour fighting for parking, then they have to sit in Sam's waiting room for an hour before they even get to see him, right? And then,
It takes me 4 minutes on telehealth. I'm not there. I'm just not
right.
there yet. I'm trying.
But it's so much more efficient. And I agree with Anil. If you're getting multiple visits for one, I'm going to see you, then I have to see you back after I order an MRI, as opposed to, you do the workup before you even come in. So by the time you actually see, the doctor, in a lot of cases, and in particularly the panels cases, we're doing surgical consults. So a lot of time we want all the information available before we make that recommendation for surgery or no surgery. You can do that whole workup before then. And then, so it's a lot more efficient for the patient.
It's very efficient. And I would say I like doing that because, it used to be 2 visits, one, a physical exam visit and one a post-op MRI visit. And now you can really make that either no visits to telehealth, but sometimes at least one. And it works either way, where you examine the patient and then you do a telehealth to get with, for after the MRI, or you do a telehealth before to get the MRI and then do the MRI at the same day of the visit because the MRI is already pre-surgered. So there are 2 different tracks you can use, 3 different and then you can always go pure virtual. So the versatility of the virtual visit is also something that you can highlight.
So one of the other things I just wanted to touch on with the telehealth visits, Anil kind of alluded to it with the caregiver. When patients come in for an in-person visit, it's just the patient. And, for the sports, for you guys with sports, if you're treating a young kid, even if they're over 18, I'm sure their mom or dad, wants to hear what's going on. For me, with patients who are older, if they have a spouse or a child, an older child who's there, helping them, nowadays we're sort of being so strict about who can come to the office. When you have that telehealth visit, you can have whomever you want there in the room with you to listen and to absorb the information and then also ask questions. So until we're able to open things up and have regular visits with whomever you want in the exam room with you, this is really the best way to have your team behind you, for your visits and for all the stuff that follows after whatever surgery you had.
The convenience is tremendous. I mean, to echo what everybody has said, that one of the things that I've learned through this experience over the last 6 months is the redundancy of things that we do and things that we've done just because that's how they've been done. And it doesn't necessarily mean that it's necessary. I think that telehealth visits for a lot of post-operative visits in particular has been transformative, for patient convenience, for my schedule, because who wants to drive in, pay for parking, like Anil said, wait in my waiting room or maybe Mark said that, wait in my waiting room for a long time, so that we can see each other for a minute, a quick chat and a wound check. I mean, I think that the power of telehealth is here to stay. Exactly where that meter will kind of land ultimately remains to be seen. Neil, when you do an MRI review and a surgical discussion, could you take us through kind of how something like that would go with a patient and what you're able to actually show somebody?
Yeah. So, there's 2 ways of doing it. Obviously, you can just look at the patient, discuss it. And, I use models a lot too. I have a femur here and you can explain things with models, and then have that connection and discuss the MRI. And via telehealth, you can actually have the pictures, as Mark was alluding to, on the telehealth visit as well and go through the actual MRI cuts. So I think those are both powerful tools to see them. Again, I'm all about less touch points. So it's, for patient safety. And I really do like Dan's point about getting more of a communal process. if it's efficient for one patient to get here, or inefficient, excuse me, it's extremely inefficient for mom, dad, and the whole family to get here. So that's really a powerful way to get everybody on the same page. I think a lot of problems in healthcare is from lack of communication. And when you can maximize communication with this kind of environment, because by definition, you're going to talk more in telehealth, and another point Dan brought up. So I really think it can really minimize kind of patients, confusion about post-operative rehab, potential complications, all the things that you really want them to be engaged about.
Dan, when you are kind of getting ready for a new patient visit, and I know I'm bouncing around a little bit, but when you're getting ready for a new patient visit, what do you do to try and prep that patient in advance for that visit? What should a patient be prepared to do?
So some form of imaging is really helpful. So ensuring that we've had some sort of, information transfer so that we can have as many pieces of data so that we can really maximize that telehealth visit, because certainly you can get a lot of information from talking, but we have removed the physical exam from telehealth. As much as you can, touch some limb, we can see somebody move around and move their limb, but we need to see things. So the best next thing is some imaging. So I think making sure that when the appointment is made, that each of our office managers is ensuring that whatever data they have has been brought to the system, so that we're not sort of scrounging for information and saying, oh, we can only go so far with this visit. We'll have to set another one up once you send us, X, Y, and Z bit of information. So I think it's a little bit more on the front end of our office managers to get as much information before the visit. But besides that, I don't think there's much. I think most of it's going to come from that conversation.
Mark, with for in foot and ankle, like how in depth a physical exam can you do, and do you do?
So I have everybody walk. I kind of agree with Anil to a certain extent that you can glean a lot of information just by having someone walk across the floor. So, that involves some of our patients overcoming some technical hurdles, right? Being able to put a video and actually video themselves walking across a living room or something at the right height. But I have everybody wear shorts. I make them take off, any socks or shoes. And I think there's a lot of information that can be gleaned just by having someone walk, and then, seeing if they're able to walk on their toes and heels and get an overall sense of what is their kind of functionality and level. I think from the exam, and you and I, Sam, we've kind of developed some of our, own telehealth exam, diagnostic criteria, and written that up. You can certainly tell things like range of motion, flexibility. There are certain tests you can do to test for Achilles injuries. All of that can be done on telehealth without an actual physician present. So I think, like I said, we're expanding this criteria, but you can glean a lot of information from that. And so for me, I have everybody walk. I'll have everyone kind of evaluate and point directly to where the spot of maximum tenderness is. And we're able to get a lot of information, and that in conjunction with the imaging, very often we're able to make very accurate diagnoses and tell the patient what the next step is.
I think that exposing the body part is important for, foot and ankle, shoulder, knee. I think that, like you said, you can get a lot of information by looking. I've been shocked how much information you can actually achieve virtually. I mean, I'm probably a little more detailed than I need to be with regard to the physical exam, but by making some minor modifications to the classic standard ways that we examine patients, you can really get a tremendous amount of information without actually laying hands on people. We've made some modifications. You can even assess strength by using common household goods and asking people to lift things. And there's a lot of information that we can get from that.
Sam, why don't you talk about the two papers you submitted for the shoulder and the knee physical exam?
Well, I would love to, Anil. That's actually a great segue. If I can, I'll share my screen and I'll show you something that I may have actually just have sitting here.
Okay.
Hold on, let's see. All right, let's see if I can share a screen. Who can share? Well, this may not work, but it worked before. But all right, let's see. I'm gonna try one more time, and then we'll. Oh, here we go.
Yep.
What can you see?
Play your PowerPoint.
You can see my PowerPoint?
Yes.
Okay.
Screen.
All right. So, so a couple of things here, and we'll see if you guys want to see it, but I can show a video. But, we've kind of put a lot into some of those things that Mark was talking about in terms of what the patient needs to do to be able to prepare themselves for an accurate physical exam. And we kind of put this table together to show if you're, for example, examining a knee, where we would want a camera to be, and the relative distance that the person needs to have available to them in order to allow us to observe all of the things that we do. One of the most important things in an exam for a lot of the joints is simply you tell us where it hurts, and not so much in the shoulder, but certainly in the knee and the foot and ankle. Where it hurts is usually where the problem is. And so, we can get an assessment of that, or things like checking for range of motion. And then things that we can do, like various tests looking for meniscal tears. We can use, household goods like a towel in order to have the patient perform an exam. And we can do other modifications of things, asking patients to turn and twist and rotate and do some other things. Like this was an example. This is a test called the lever test, which is not very commonly performed in the office historically, but is a really good test looking for ACL injury. And what makes it a really good test is it doesn't require you to feel something, but it gives you an objective measure that you can actually visually see. And so there's a lot that we can do, and through the power of observation over the internet. I mentioned household goods, so we can use things like canned goods, or jugs of water, or gallons of milk that have known weights that we can use for strength assessment. So like in this slide, for example, you can see we've got eight canned goods in there, equaling, 8 canned goods in there to allow us to assess for rotator cuff strength. And it's not perfect, but it's a good opportunity. And this is something that I don't necessarily do, but it does show you the power of where things like this are going. The use of things like virtual goniometers over the internet on a static image that we can take to assess pretty accurately things like range of motion. And then down here, when we were talking about going over MRIs, we have the ability to share screens with patients and be able to go through the MRI, sometimes frankly even better than you can go over an MRI with somebody in the office. So I think that there's a tremendous amount of things that we can do from an examination standpoint to overcome some of the obstacles that that certainly made me objectionable to this whole notion before it ever started. Any thoughts on that, gentlemen?
I think one of the really benefits is the pre-surgical discussion, going through the risks that come with surgery. Years ago, there was a study, I think it was on neurosurgery patients, where they, I think a month before surgery, they told the patient like 30 something minor risks and 6 major risks. An hour after that conversation, they asked the patient what they could remember, and it was frightening how few of the risks the patients actually remembered. So again, it's that comfort of your home, having other people there, being able to just sort of absorb information a little bit better. And I mean, it's very important information. Preparation, as we all know from our experiences, when our patients prepare more for surgery, mentally, physically, and their home situation, they just do better. So getting that family member involved, having more understanding of what's going to happen right before, during, and then after surgery, I think is really critical to getting our patients better faster.
Dr. Dracos, do you have any thoughts?
One other kind of nice thing about telehealth is that, and we kind of touched on it before, is you can get multiple providers on the same telehealth conference. So if a physical therapist potentially has an issue with a post-op patient, the three of you can actually do like a conference call. I've been on conference calls with physiatry, or like I said, telehealth visits where you can kind of, like we are now, it's almost like a panel. And so you can almost have like a group discussion with the patient, as opposed to having multiple phone calls. It actually kind of consolidates things. You know, and even in the future, you know, in terms of how this thing is going to expand, I think kind of the sky's the limit. You know, we all probably use our smartphones way too much. I've actually done telehealth from my smartphone once. And it's going to maybe get to the point where patients have access to, you know, providers through their phone very quickly. Depending on, you know, what the issues are and what the providers can provide.
Do you guys think that telehealth is a bigger advantage for patients, physicians, or equal?
I would say equal. I think it's, you know, the patients don't want to schlep down here. And if considering that we're pretty good with our diagnoses because of the physical exam maneuvers that you showed, Sam, and because we can organize, like Dan said, and get all the imaging beforehand and everything's uploaded. And then all the, you know, all the points that Mark pointed out. I think one thing that I really like is I do a lot of telehealth with both the patient and the physical therapist. So we're all on the same page. That's a really powerful tool when, you know, so much of what we do is after surgery is post-operative rehab, and knowing when to push a patient a little faster or slow them down, and having the therapist together and everybody engaged. And the therapist is in a different facility, the patient's at home, and, you know, and we're in the hospital. So it's a powerful tool that really helps everybody.
I would ask for anybody that's out there watching, if you guys have any questions, please feel free to put them in the Q&A so that we can address them. And also maybe if some of the viewers want to mention concerns that they have, or really positive things that they've had with telehealth.
Sam, there's one question here. One viewer attendee said, you know, what's your patient feedback on telehealth? We're all saying, you know, what our feedback is. I don't know if we'll start with you, Dan. Have you gotten any feedback from your patients about how they like telehealth or don't like it?
Yeah, you know, usually the end of the call, you know, almost every time they're very happy and they're very thankful. And yeah, I don't think there's been any negative feedback at all. And I think, again, it just goes to that face-to-face interaction and having that full chunk of time with the doctor. You know, a lot of times you come into the visit, you check in, it may seem like you're there for a long time, but the actual doctor-patient time ends up being not that long. But this really is, you know, there's not a nurse involved, there's not a medical assistant, it's just you and the patient, and that's it. And I think that the patients thus far have left getting the information that they needed and are perfectly satisfied with the entire, you know, situation.
Yeah, I would echo that.
I think there's one, you know, we all had probably hesitation that telehealth would be more successful, you know, based on the patient's age maybe, and that younger patients would respond to technology maybe a little better than older patients. But from listening to Dan and other of my, you know, arthroplasty and spine surgeon colleagues, they've embraced it. As Mark said, that we all use smartphones, and so I was expecting my older patients not to appreciate it as much as my younger patients, but I have not found that. I don't know if anyone else has found that. If anything, I've had them like it more because it's much harder for them to get around and to get to the hospital and move around.
Yeah, I had no idea that my 80-year-old patients were as tech savvy as they are.
Exactly.
It's been pretty amazing, actually.
And at this time, they're the ones that are the most at risk. So I think that they're very happy with the option of doing something like this.
Mm-hmm. We had another question from Patricia. She said that I've got lower back pain after walking short distances. What can I do to have a successful first telehealth visit? Like what can she do beforehand to try and make that visit the most productive possible? What do you think, Dr. Dracos?
Just to consolidate all the information that she has at her disposal, specifically, did she have an injury? Has she had this in the past? Has she had any prior surgeries? Does she have any films? The more concise she can kind of form a story and deliver that story to a provider, I think the better the visit that she'll have. And then ultimately, like picking the right provider for her. A lot of times people will come to our office or do a telehealth visit. It may not be necessarily the most appropriate. They may not need surgery. Certainly, for someone with just generalized low back pain, I wouldn't necessarily schedule a telehealth visit with a surgeon first. But we have plenty of physiatrists who can appropriately manage that type of symptom.
I think one of the things that you said, Mark, is really, really important is the more information that exists that you can bring together for review, the better. So, if things have been done in the past, or there's a long history of things, or things that you've tried and have worked or haven't worked, that information is very important to kind of be able to triage the problem and be able to get it where it needs to go, get the imaging that you need. And it kind of, that parlays into another question from Robin here that says, what's been the biggest challenge as a physician that you want patients to know? And I would say, for me, it's probably that. I think that one of the things that's most frustrating for me is when somebody's had a bunch of things and it's not available to review. They've had prior surgery and they don't have any information about it, or they've had an MRI, but they're not able to load it or provide it beforehand. So, where the imaging is helpful and the information for us to be able to kind of synthesize that information and help progress that patient's story is helpful. And when it's missing is most frustrating to me. What do you guys think?
Yeah, I mean, you can make the argument that patients are more organized for telehealth than they are, I'm going to go see the doctor, and then, they'll figure it out. Dr. Taylor will figure it out. And so if you're relying more on a electronic visit or a telehealth visit, I think they're more compliant of checking all the boxes to make sure they've really fulfilled all their paperwork beforehand, so you have a very efficient visit. I want to just touch on one thing about the patient with the low back pain. Realize low back pain is the number one reason why a person in the United States sees a physician, and it usually does not require a physician to move them on. It's usually more of a consult to physical therapy. The number of people with low back pain that needs at least a surgical evaluation is a very, 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 very small percentile. So that's a perfect example how you can be extremely efficient, not waste your time as a patient to get hooked in with the right physician, as Mark said, if you need it, or getting hooked into the right physical therapy. So that's probably one of the best examples where telehealth can really make it, really help a patient out.
So there's another question here from Rose, which is I think a really a story that goes with the question that I think it really drives home the point. So she's had several surgeries in the past and normally gets an annual follow-up with an x-ray, and is coming from Long Island, doesn't want to use the trains now due to COVID for obvious reasons. She says, how important is it to have a yearly x-ray for my visit? Otherwise, I would consider a televisit. And what I would say to that is, first, that's between you and your surgeon with regard to the x-ray. But secondly, what I do for my shoulder replacement patients that I get an x-ray on for a follow-up in the future is I have them get a quick x-ray at a local facility to them and upload the x-ray, and then we do the visit telehealth. That way it can be a quick visit local to you. You don't have to travel anywhere far. You can remotely upload your x-ray, and then it can be reviewed, and then the visit can be done virtually. So if the x-ray is important, it doesn't even mean that you have to come to HSS to get that information. It can be done. These things can be done locally and uploaded. It's pretty amazing.
Yeah, I totally agree. I think that's going to be, I'm sure Dan can talk about this. That's going to be the standard of care for post-arthroplasty follow-up. Dan, what's your philosophy? Because that's usually a really large waste of time for looking at a small percentage of patients that actually need an intervention.
Yeah, I think that, the first year after the joint replacement, you're keeping a little bit of a closer eye. But once you get to that, 1 year, 3 year, 5 year, 10 year, yeah, I mean, we're kind of surveying things because we're requesting the patient to come in at those longer time visits from their initial surgery. So it's more for us to catch something before it turns into a problem, because oftentimes with joint replacements there may be changes going on in their replacement where the patient doesn't notice it, but then we can catch it earlier and do something about it. So just like that question about an annual x-ray, again, it's a perfect telehealth visit. And I think, again, it's more convenient for the patient, and it doesn't fill up the surgeon's schedule with really what probably ends up being 5 minutes where they come in, I'm doing great. Yeah, my hip or my knee is doing great. Look, x-ray looks great. Thanks. See you in a couple of years. So I think that could really make our system much more efficient. And I think in general with the telehealth visits, what I foresee, and I think we're even looking into this on the arthroplasty service, expanding this to inpatient care. So I think that there will be an evolution, and who knows where this lands, on its feet for the final, once, ideally COVID is gone. But I think if anything, this is not going to get smaller, but rather it's going to get bigger and expand to different areas of medicine.
I'm actually doing surgery virtually right now while we're on this call. I'm actually operating virtually. So who knows where this goes? It will be amazing. If there are no other questions, I guess kind of parting words from each of you guys, if you want to just share a couple of parting words, and we'll wrap this thing up. I know that it's been a good conversation with some good buddies of mine, and on a very relevant topic which is telehealth, and something that is certainly here to stay. It's not leaving anytime soon. For me, like I said, it's been a very positive experience for patients and myself, and I look forward to seeing how things continue to evolve. If you guys have any additional thoughts, parting words.
I mean, I think this is a true game changer. Once you see the efficiency, I had, this kid today when he said, so doc, next visit, I have to come down from Massachusetts to see you. I go, no, we'll do the same thing in 6 weeks. We'll see how you do. I'll check your motion, see if you have any pain, and then we'll get you back running. So that was really true to me. I'm like, I'm never going to do follow-ups for my patients who travel quite a bit without telehealth. And there's been a lot of times I haven't had follow-ups without telehealth because it was just too impractical. Someone drive 8 hours from way upstate New York to come see me. So I think it's really a game changer, and I think patients are going to love it. And I think doctors will get better at it. Our exam will get better. Our uploading skills will get better, and it's here to stay.
Dracos.
I would say, the one constant in this business is change, and that we all have to evolve. I think we embrace this, and we see how it can be utilized. We're still developing a lot of these, protocols and kind of our routines in terms of post-op, pre-op. But I think I agree with you guys. I think it's here to stay for at least the immediate future. I think it has the safety benefit of minimizing exposure for patients and the convenience of not having to travel. So, I've enjoyed it, and I think that I look forward to all the places it's going to take us and how this continues to evolve.
Dan?
What all they said. I agree.
All right, good.
Yeah,
good.
I don't think I have much to add, but I totally agree that this is here to stay and it's going to expand.
All right. Well, I thank you guys all for your time and your expertise on this topic. And I thank the participants for hearing us out and asking some very good questions. And we look forward at HSS to being helpful telehealth in person, however we can be. So have a good night, everybody, and thanks.
Thank you, everybody.
Good night. Thank you.